Welcome to Medical Grand Rounds. Good morning. This is our 8th attempt at a Zoom Grand Rounds and probably the 4th time we're covering the COVID-19 topic. So let me just quickly go over ground rules for participation. So the only people who will share audio and video are the panelists. I have a lot of panelists today. So you'll see 8 of us on the screen. The agenda is Dr. Lesho is going to spend a few minutes telling us about epidemiology and the new things that they've gathered with that. And then each of the other doctors will do a short personal statement on how COVID has affected them. If you have questions for the audience, and I'm expecting most of the questions might be for Dr. Lesho, please put them on the Q&A rather than the chat button. And the panelists will be able to see the Q&A. Depending on time, I might not get to questions until the very end because I want to give us enough time to go through all the presenters. So without further ado, I am going to share my screen so Dr. Lesho can start. Dr. Lesho, your first slide is on.
Okay, good morning, everybody. I'll be real quick here, but I've been over the week or so getting a lot of questions on how close were the predictions and where we're standing and why we're seeing more tests, but we're still, how are we doing with the phases of opening? As of yesterday, this is the report from Monroe County, and you see that the tests are, the positivity rate of the tests is happily remaining somewhere around 10% or less. So that's fairly good news and fairly stable, and you could see the totals there. Next slide, please. If you want to summarize it by a week versus a day, you see a lot of positive tests beginning in May, likely related to the mandate of nursing home testing. So employees have to be tested twice a week if you work there more than 3 days a week, and once a week if you work there less than 3 days a week. And that drives a lot of the cases. And whenever an employee tests positive, you have to do contact tracing on the patients there. So that's why you're seeing there. But again, the percent positive is relatively stable. Next slide. And then the other question they were asking is, well, did we see the number of hospitalized cases that we were projecting? I think overall, the people, the virologists and some of the experts that are in respiratory viruses and epidemiology were saying, well, if you compare it to typical respiratory virus season, we were expecting about 20% of the patients, we were expecting about 80% of the people getting infected of the population. About 80% of that, we were saying likely you could see 20% in the hospital, and that's pretty much what you see. In the middle there, 19.2%. And then we were expecting up to 40% of that percent in the ICU. And so that was what we missed on was probably maybe how infectious and how fatal the virus was actually going to turn out. So you see there a case fatality rate of 7.5% as of last week. Next slide. And I mentioned the nursing home. This is from the dashboard. Increasingly, the dashboard or the click view can track more and more data points, and this is just the number of new cases over the last period by nursing home facility. Next slide. Total. So across the system, yes, 2 days ago at least, we were running about 60 to 63 patients. There was one death and there was one transfer back. So that's across the system. You could see, you can't see, RGH is yellow. Next slide. discharge by facility, it's self-explanatory. Next slide. Deaths. It has been specifically, and then you could see, no, that's fine. We can go to the next slide, Dr. P. Yep, and some Hillhaven, for example, has several units, and you could see the dementia unit, which is Fairhaven, has a very high prevalence rate there. And then we'll get to that. That relates to, I think it supports our conclusion for the outbreak on 7800, which we'll come to shortly. Next slide. Clifton Springs, one particularly hard hit area there with a prevalence. Next. And the next, just go through the others. So next slide. So I think finally I'll end up with, I think a lot of people were interested in this. We had, through the support of Dr. Walsh and his research efforts, we had the opportunity to test almost 225 healthcare worker volunteers for antibody testing. And the final results, including the statistical analysis we just completed. So there were 5 indeterminate. So too strong to call negative, and too weak to call positive. So overall, we had a positivity rate overall, all comers, of 8.7%. But the real reason we were trying to do that was because it was part of our case control study. And so we looked at how do the rates compare across a dedicated COVID unit, which we used MICU and 4800, compared to a non-COVID unit, which we used 2800, and then the outbreak unit. And those are the actual numbers of the test that we did there. Next slide. So, and here's how you can see this visually. So if your average positivity rate of the units, those units overall, was about 11% positive. You had a lower rate, significantly lower rate of having been exposed, infected, exposed, and mounted an antibody response if you were on the non-COVID unit compared to the outbreak unit. But there, I mean, it's visually interpretable there. So the outbreak unit being 7,800, and you can see positive there in red. So next slide. Getting into the actual final statistics, you almost had, so non-COVID versus COVID. So if I compare 2,800 to 4,800 and the MICU, the good news for everybody is that you can take away from you could say, well, our PPE is working, or what have you, but there's no increased odds of a person who works on a dedicated COVID unit being exposed compared to a non-COVID unit. When you look at 2,800 and you compare it to an outbreak unit, your risks, you have a lower chance of being exposed compared to the outbreak unit, which is significant. But if you are part of the outbreak unit and you compare yourself to another positive unit, you're almost four times more likely to be exposed and mount an antibody response. And I thank Dr. Bress for helping us out with those statistics. And then next slide. So another way to look at it, no increased risk of exposure on the COVID units. If you're working on the COVID units, that's good news, as long as you adhere to good measures. Hand hygiene is really important. And I want to demonstrate that here because we also have, well, I guess you can't do that. How does that work? Oh, anyway, there's a nice visual graph that didn't make the final cut. But hand hygiene on the outbreak unit was significantly lower compared to the other control units and compared to most other units. So it emphasizes the importance of hand hygiene. So the takeaway message for all of us is face shields are an important factor. Hand hygiene is an important factor. Unexpected, uncontrollable movements of patients who are demented, who have mental illness. These are all risk factors. So if you're in a situation where you don't know the status of the patient and you have to grab some piece of protective equipment in a hurry, grab the face shield. And that's one of the reasons why we changed the policy from recommended to required for patient contact. And then I'll end with the ongoing resident projects. We have Dr. Hannah and Chen had developed a registry, a COVID registry, which continues to be optimized and grow. There may be upwards of 400 patients in that now, and that's becoming available to others if they go through the IRB and seek a simple thing. And Dr. Pandela and Ahmad Udin and Mananga have done that, and they're looking at that. And then recently now we're expanding some serology there. And so I'll stop there and turn it over to the next panelist.
Okay, so we're doing well on time. I'm going to do a quick audience poll to see who's there. We have 233 participants. And so which of the following describes you best? And you can vote now.
Pretty sweet, huh?
Okay, wow. So we have 16% primary care docs, 7% hospitalists, 31% specialists, 17% APPs. Another quick poll. Normally we end grand rounds for the summer in the middle of June. And I'm thinking because of this COVID, people are looking for updates. Should we do one grand round during the summer, keep doing these every 2 weeks, or keep doing these every 4 weeks? And if you would answer now. Okay, I don't think I need more. Overwhelmingly every 2 weeks. All right, we shall keep doing that. So the rest of this is going to be sort of like a round table with 5 to 7 minutes per presenter. Let's see what we're doing on time here. I think we're good. I can tell you personally that Department of Medicine has been drastically affected by this. So I have sort of 2 jobs. All the things that I do administrative with credentialing and the meetings and so on, that's all gone virtual. I have to learn how to use Zoom and, been doing all this stuff remotely. On the cancer center side, though, we have not been able to stop any of the ongoing cancer care because this is all hands-on infusions and so on. So our infusions, we're still doing about 80% of what we were doing before COVID. It's dropped a little bit because the referrals have dropped. And I think that may be in part because the elective surgeries have dropped. But I think that's going to pick right up as people start to get diagnosed again. We've gone to televisits, and that's different. And I don't know, personally, televisits are okay for some things, but for some things you really need the hands-on. So I think televisits are here to stay at this point because we've swung so far in the direction of doing them. But I think the pendulum will have to swing back a little bit to balancing who needs to be seen in person versus who needs to be seen by telemedicine. On a personal level, the most difficult thing for me has been the inability to connect with young people that we were connecting with on a regular basis. So my nephew and his wife live like a block from us. They have 2 little kids who need to go to daycare. And we've been distancing from them for 3 months. And it's just hard because Alka and I are both in our 60s. We're considered high risk, don't want to be unnecessarily exposed. And it's just turned our lives upside down. So with that, I guess I'm going to pass the baton here to Dr. Robert Tripp, Chair of Surgery, Rochester General. Bob.
Thank you, Prad. When I was asked by Prad to present, of course you say yes when you're asked to do something. And I think that's been a theme throughout this crisis is when you ask people to do something, they generally say yes. Sometimes you get a little pushback, but when you talk things out, most people are more than willing to help and do what's asked. I hope that, as I share my experiences, sometimes you think you're unique, sometimes you think you're the same as everybody else. Hopefully this isn't redundant, but maybe it validates others' experiences as well. throughout this, I think it's been helpful to focus on three objectives for everything that we did. One was what's the best for the patient. And sometimes that meant not doing anything. It goes back to our Hippocratic oath of doing no harm. We canceled an awful lot of elective surgeries. Some people were grateful to have it canceled. Some people were upset. But you had to try to remember what was best for the patient. And a lot of this was unknown. So we made decisions with the knowledge that we had at the time that was as best as possible. And then altered with decisions as we went forward based on what we learned through our experiences and through others' experiences. The second thing that we kept in mind the whole time is what did we need to do to keep our staff safe and our providers safe. And again, that was a huge motivating factor, and it was an overriding decision maker for everything that we did. We also wanted to help our staff and providers to be as prepared as possible for whatever came along. We redeployed people, we sent them to help others, we sent them to get training so they would be prepared if we became overwhelmed in the ICUs or the floors, whatever would happen. Again, that was an overriding theme of how we approach things, and my personal decision making whenever we had to make decisions was revolving around those three things. Throughout, we faced a lot of challenges. A lot of it was focused on resources. Initially, it was how do we cut back to save resources, PPE, patient beds. We canceled surgeries to protect the patients. We canceled surgeries to protect our staff from the patients and their families bringing people in. Visitors were curtailed. That led to another challenge of how do we communicate with families? How do we communicate instead of face-to-face? All of a sudden you're making a lot of extra phone calls, a lot of extra time. Saving the beds for the patients that were going to need it from COVID, the ICUs, the ventilators, all those resources. And we continue to have to manage all that to maintain our openness, our state criteria to stay open and do elective surgeries. Were all important. The other personal thing I felt was a constant thirst for knowledge. I've always wanted to know more. I've always liked every rotation that I did. But that thirst for knowledge to know what the truth was at times overwhelming. What was really the truth? And a lot of times we didn't know what that was. And, that could be very frustrating. A lot of people were sending me papers left and right. I had one of my partners was sick. We thought she had COVID. Turned out she didn't, but still was out for a couple of weeks with a severe illness. And she was, with her time, she was sending me paper after paper and experience after experience. And as were other physicians, some of them very helpful, some of them challenging in that, we shouldn't be doing this or that, and others were pushing to do this or that. We were, in that respect, we worked on protocols for tracheostomies, which are high-risk procedures. We worked on protocols for PEG tubes, still a high-risk procedure, although not as high risk and maybe not as urgent, but trying to determine what the best was for everybody. And different people had different experiences. Some people were quoting people that were dying because they had done oropharyngeal procedures before they really knew the risks, and young people that were dying. And that would taint our experiences. And another personal note I think that was challenging was the balancing act of appreciating people's experiences and their personal, where they were in their lives, whether they had illnesses, whether they had family members that had illnesses or exposures, and not judging their sometimes emotional response to a thought process or an ask. Tracheostomies was one of the big ones that came to mind, and some people were pushing to do things, some people were pushing not to do them. What was the right thing to do? And in the end, I think we talked everything out. At times people would get a little upset, but if we talked and were honest with each other, I think it worked well, and we came to solutions that were very helpful. I certainly wrote a lot more to talk about and challenges and things, and I know Brad wants to keep to a schedule, so I'll skip some of it, but I think that communication was a huge challenge, remains a challenge, as everything, all the changes that take place day to day, hour to hour, you'd write things and trying to get people to read them, or by the time you wrote them, they're out of date, you had to rewrite it. I had spent a huge amount of time performing all those acts, trying to keep people informed. I will say that some of the good that came out of this, the relationships that we had developed all along, the teamwork that we have always done in the Department of Surgery kept us strong, kept us unified, and we adapted to all the challenges that came before us. And I think we did an excellent job. I appreciate the team members that I worked with, the leaders that I worked with, and those relationships that we developed, have paid off. You do have to trust your colleagues. You do have to be honest with each other in all this. But it's been rewarding in that sense, and that I think we've done a good job as a community. It's also been heartening to see how the community responded. Ralph Benino went out and asked companies to build face masks, to make face masks, to do face shields, and we had Vietnamese church groups making face masks with their own money. Companies diverting what they normally would do for income into things that would keep us safe. So it's heartening to see that response by the community. It has been a challenge, I think, for me personally with my family. My kids are both out of town. Both stayed where they were working, and it left my wife alone a lot when a lot of her friends had their kids home, had their husbands home, and I was gone just as much, if not more than ever. The work changed. We still took care of the cancer patients. I'm a general surgeon. I still took care of the urgent patients. So we still had clinical responsibilities, but a lot more administrative. The weekends were just as bogged down with work, if not more so. And we convened different groups of docs and APPs to try to manage all these changes in real time. But I think we've met the demands, but worked hard to do that.
Thanks, Bob. So the next three speakers are people who've really been at the front lines caring for the hospital COVID patients. So I'm going to start with Dr. Laurie Lerner, who is one of our ICU physicians, and I don't think needs any introduction to this group, but Laurie, it's all yours.
Thanks. Good morning. Thanks for inviting me to share my experiences as one of the pulmonary critical care docs here at RRH during this time of COVID. Most of you know, or many of you know, I'm also a single parent. I have 2 teenage daughters, and I thought I would share some insights of navigating those 2 roles during these past 3 months. So last night, I was kind of trying to decide how to present this, and I dissected my Outlook calendar, just looking at all of the meetings and my rotations, and then I spent some time on Google looking at what was happening on that day. And I pulled out a few critical days that I think stand out and are worth kind of looking at in detail what those days look like. So January 2020, life is humming along. The MICU is busy. We're always busy, fighting for beds, looking for space, you know. But it's challenging, you know, a strong, cohesive group. My daughter, Anna, 17, in 11th grade. Lily, 15, 10th grade, Brighton High School. So they're busy riding horses, planning college, doing all those things, taking AP classes. They're planning and packing for their student exchange that's going to leave the next month. So fast forward, January 31st. I'm in a restaurant with a friend, watching the TV, and there's that video that, of the hospital being built in Wuhan. And I thought, holy smokes, you know, that caught my eye. You know, we'd been hearing dribbles of that the virus was coming. I had this tingling sense of worry. I'm like, this is real. But life moved on. We were busy as usual. The MICU was super busy. Outpatient was busy. My girls were busy. 1 week later, February 6th. So then the news reported a death. So Dr. Li Wenlang's death. I remember that hit me like a ton of bricks. Physician death, oh my gosh, you know. But it was still far away. We felt safe. we were still busy. Everything was moving along. Life was moving along as normal. MICU was moving along as normal. So then 1 week later brings us to February 12th. So that's the day my daughters departed for Germany. I was a little worried, mostly about the airports. They were flying through Newark and then landing in Berlin. Seemed okay. There was a few cases in Italy. I instructed them on hand washing. That's about it. But then while they're in Europe, the outbreak in Lombardy, Italy unfolded. So as a mom, that's just horrifying. I was worried. I was worried as they traveled Europe. They actually went to a celebration, a festival celebration there. But they made it home okay. They were well. And I was relieved. They were back in the US. It felt safe. The MICU was still as busy as ever. No COVID cases. We were humming along as usual. And what's amazing to me when I look at my calendar, it was a full month later before there was kind of a sentinel day. And then, so it's March 11th, and this is what I call it's getting real day. So 3 big things happened on that day. So the Atlantic published an article called The Extraordinary Decisions Facing Italian Doctors. And that popped up in my Facebook. And it basically looked at the decisions facing those Italian doctors. It discussed their agonizing dilemma of rationing critical care, rationing services, and ventilators. The second thing that was reported that day was a second death. Dr. Roberto Stello, 67-year-old Italian doctor. So this was shocking to me. Physicians are dying, not just one physician in China, but now an Italian doc. And, we had lived through Ebola and, we had done SARS and we had done MERS and we were okay. And, we had kind of thinking this would be the same. Started sinking in. And then that night, I think most of you remember the Jazz NBA game. There's a confusion at the beginning of the game and then the audience just trickled out. And then the dominoes fell, like life changed, like in the hospital, out of the hospital. School was canceled. And the MICU was still full and busy, but all of a sudden, we felt really vulnerable. And we're thinking, how in the heck are we going to take care of all of these patients? And at that point, it felt like the tsunami was coming. We were watching Lombardy surge, and at that point, it felt like it was just a matter of time before that surge came. And then it was in that moment that I reflected back on the images of Dr. Wen Liang. And I was kind of looking closer at those pictures, and I'm like, oh, look, he's wearing both a high-flow nasal cannula and a venti mask. And I'm asking myself, why? What happened there? Like, did he die with a ventilator, or did he die without a ventilator? And, so the question is, did he just die despite the fact he got care, or did he die because he didn't get care? And either of those options were just maddening, as a critical care doc. And so I'm the medical director of respiratory therapy. And in the past 6 years, that position has been just administrative protocols, getting ready for JACO. And on March 11th, that totally changed because it became abundantly clear at that point we could run on ventilators. And then ventilators essentially became my life. So less than a week later, after those articles, the Get Real Day, March 16th, we have our first COVID case in the ICU. And that same day is the first day of homeschooling. So I think my experience being a homeschooling mom was very different than many other moms. First of all, I'm not sure how you're supposed to homeschool, sophomores and juniors taking AP classes. And then I'm obsessed with the ventilators. And then at that same night, I realized that I probably should be separating from my family. So I went online at Target and I ordered a microwave, a toaster, a coffee maker, and I loaded up my stuff and I moved out to this apartment above my garage. And I feel like my girls grew up that day. They knew they were going to be on their own. I emailed my daughter's teachers and I explained the situation. I kind of pleaded for them to maybe look out for the girls, give them a little help with their work, give them a little leeway when they weren't doing so well. And then in the MICU, things were tense. No one really knew what to expect. No one was really familiar with the PPE yet. There was a lot of different discussions about what kind of PPE we should wear. Should we reuse it? How safe are we? No one knew. It was scary. And so then the next month, so I say this end of March, all through April, was just a blur. Skype meetings, Zoom, doximetry visits. I was focused on the ventilator and developing assets and then also ventilator allocation. So I was kind of working in parallel. In the RT department, we were trying to reconfigure our CPAPs to be using them invasively. We were working on ventilator sharing. We're consulting with RIT and trying to develop, rescue devices. Manufacturers were willing to spend millions of dollars to develop a rescue ventilator for us. It was kind of an exciting and scary and kind of amazing collaborative time. Leadership was engaged. There's kind of some amazing collaboration that developed was strong, that had been missing for a long time. There was a group called that we dubbed the Throughway Call, which developed. It was essentially developed by David Kaufman over at Strong, and he organized about 70 docs from Syracuse, Buffalo, all the hospitals along the Thruway. And we would meet about every other day, every third day, and just talk about what's happening in your hospital. What are you doing? How are you addressing this? And it was amazingly supportive and informative and kind of exciting. So then the MICU, at that time, people were becoming more comfortable with their PPE, more comfortable with this idea of COVID, but we were still counting our cases. But at the same time, my inbox was filling up with emails from my kids' teachers. So they were missing assignments. They were not joining their Zoom meetings. They were not taking their exams. And I kept filing them away into an inbox thinking, I'll get to this, I'll organize this for my kids. And I just couldn't. I couldn't do it, and that guilt was horrible, and I kept thinking, I think my experience is different than all the other homeschooling moms, and I just had to kind of stop being on social media and hearing about that. So I think at one point, I think it was Dr. Mayo had said on a meeting, we're fixing the plane while we're flying it here. And I thought, that really resonates. I feel like that's what I'm doing. So for me, I had this visual image during that time of flying this plane full of patients, and they all needed ventilators. And I kept looking for a way to land it, some resource, some way to get them all into the morning alive on this airplane, I didn't know how I was going to do it. It was scary. And then along comes May 1st. It was like May Day. Something kind of magical happened come May, though. I feel like that curve, it did flatten. And then I had this image of this airplane, I'm coming in. I'm pulling up, and I'm coming close to the ground, and then we just skim, and I come into this ugly landing. It's like, oh my gosh, we're alive, we're all okay, So, in the MICU, a strange thing happened. We all kind of looked around and we realized, oh, we're all alive. We're all okay. This PPE thing works. We're not getting sick. We're all kind of comfortable with COVID. We've kind of learned more about the disease. We kind of understood the coagulopathy or starting steroids. We got better at the ventilator management. And so things were kind of relaxed. So then in May, what I started seeing in the MICU was everyone started kind of having these conversations with each other saying, hey, are you going back into your house? Are you back with your family? And everyone had been, kind of independently coming to this. And then so we started having these strange conversations about kind of these purification rituals that we have as we leave the house and go home, So, that we change our scrubs and, wipe down our glasses and our shoes and, strip down in the front yard or, so then I I kind of start developing this image of myself kind of like a superhero, changing out of my like hero costume at the hospital and then, going home. But then I'm thinking, oh, I'm probably like a lot more like the Incredible Hulk than I am Wonder Woman. Because, the Hulk is kind of like potentially scary and radioactive. So, you develop this disconnect between like these threats that you have at the hospital and kind of this person you are at home. And it's a little bit hard to kind of reconcile being hero and pariah at the same time. So, but my girls were remarkably good. They were calm. And it brings us to June. And here we are. It's kind of our new reality. We didn't get hit with a tsunami. It's a little bit more like a lava flow. And so we'll see what happens next in the world. Thanks.
Thank you, Laurie. So next, I'm going to move to Dr. Sani Bujalo, who's one of the hospitalists taking care of positive patients in the hospital. Sani. In the meantime, real quick, Dr. Lesho, if you can look at the Q&A, there's a bunch of questions there for you that maybe you can just answer online because I don't think we'll get to them in the end.
Thank you for having me, and good morning. As Dr. Fatak said, I'm one of the medical hospitalists taking care of COVID and sick non-COVID. So being a hospitalist it had a new meaning to me with COVID. How do I save lives? How do I alleviate suffering? And then how do I take care of myself, be safe, and also take care of my colleagues by keeping myself safe? It became an much more connected group. The meaning of teamwork changed to me because I saw that teamwork was making sure that you do ideal infection prevention to keep the whole team safe as we all work in a group. With COVID, I have become hypervigilant, but also I try to exude a sense of normalcy as would all our hospitalist group. Make sure that patients don't see that you see them differently in any way. I try to exude that normalcy, that you are just the same as any other sick patient, and everybody else will take care of you. I would say that my hypervigilance in March has changed in June. To me, it's becoming a normal, just like Dr. Lerner said, and I'm sure I would say that for everyone in our hospitals group. When it comes to my department, the safety of the whole hospitalist team was at the forefront of our leadership. A lot of changes were made just to prevent or decrease exposure to our team. Our schedules were changed to strict 7 on, 7 off. So half the group would be working at any given time, and the other half would be at home, social distancing. Our APP group was with us every step of the way. Pulmonology and infectious disease became our best friends. We would call them every time. And also the internal medicine group bent over backwards to accommodate our new schedule in the setting of COVID. Our unit meetings became more about COVID or COVID related. Always trying to educate us as to the new and changing guidelines when it came to COVID. And as a member of the representative of the medical and dental staff, our meetings were consolidated. However, our work did not change. We continued to vote for policy. We continued to facilitate in recruitment. And we also continue to uphold quality and safety. COVID did not change that. When it comes to my personal life, my 4-year-old, interestingly, is so much into social distancing. He would ask me when I come home, because he likes to play with my phone, he'll be like, "Mommy, did you wipe down your phone? I need to use it. I can't use it if you don't wipe it down." The sign of the times. We have come to appreciate as a family the work that teachers do for us, having to homeschool. The whole burden is on my husband because I'm a bit too busy taking care of others. So that's definitely been a change, but we are closer together as a family. My colleague and office mate, 3T, had a birthday party for her daughter, all on Zoom, and it was equally beautiful and equally nice. So those are just some of the few changes that COVID has done in our lives, in my life, and in our lives as hospitalists as well. Thank you.
Thank you. So our next speaker is Dr. John Hanna. He's one of our third-year residents, actually graduating this month in a ceremony that we hope will be a small in-person ceremony. We don't want to do this remotely. And John is headed to Texas to do an infectious disease fellowship. So, John.
Thank you, Dr. Buttock. I'm going to be presenting a small piece similar to the Bernstein style. In summer of 2019, as a bright-eyed second-year resident, I traveled around the States during the match interview season, trying to advocate the importance of creating a combined infectious diseases and informatics fellowship. At that time, I failed to mention the possibility of a pandemic that I thought only exists in textbooks. But who would have guessed, at a time when our biggest challenge was MDROs, when airlines were still operating, when 40 million Americans were still employed, and when many of our elderly were still alive. In early December 2019, when I joined the vibrant infectious disease community, I had dreams that we may be able soon to end an epidemic, HIV. I didn't know at that time that another more deadly one is on the way to change everything. As COVID arrived in March 2020 to New York, physicians knew there are going to be changes that we have to adapt to. The way we see patients, the threshold to make a patient come to a medical facility, and the clarity about the uncertainty of advice provided in certain circumstances. As residents, however, learning is empowered through a variety of in-person rotations. Many of these were deemed undoable as the whole system switched to a telehealth approach to avoid any unnecessary exposure. At that time, my HIV rotation was canceled and ID sounded to me as a preferred alternative option. I stayed on ID for 4 weeks, mainly learning and helping the infection prevention team. It was such an outstanding experience to witness our ID department's critical response amid the pandemic, with all what came with it from uncertainties, obligations, and around-the-clock updated information. I witnessed hard work, compassion, and professional flexibility. I appreciated the field as never before. Accordingly, I felt also obligated to utilize my informatics interest to try to answer questions, find patterns, and provide data for surge modeling under supervision of Dr. Lashon. Going through COVID patient charts, establishing a database that was used later as a seed for the system COVID registry, I learned a lot about these patients in different settings. But despite everyone working hard on finding predictive indices for outcomes, unfortunately, it sounded more like a coin flip. If a patient seen today will continue to be at the same level of care tomorrow. Patients were sent home with pulse oximetry to recognize silent hypoxia. Less critical patients were admitted to higher level of cares for monitoring as they decompensate rapidly. And protocols continued to change spontaneously. It sounded scary in many circumstances to say that we actually have nothing to offer. There was no treatment approved, and everything was advised to be utilized only in clinical trial settings per IDSA. In a rapidly changing pool of knowledge about COVID, data is the drive of surge planning and on a narrower level for educational opportunities and schedule changes for residents. Our program stepped up with a system to face our current stage. Many residents were placed on home learning rotations to be available to cover on core rotations if needed. Our residents-run clinic also adapted the telehealth approach, and residents in the ICU took more days off to recharge. As flexible as it can be, weekly check-in meetings with an indescribable support and response from our program leaders to our suggestion took place. Since I started my residency, I've been always impressed by the human factor in the program. That support that never failed a resident no matter what. On another aspect, as many of us are international medical graduates, many family members overseas live in highly populated cities, where the average level of education is below average, which is challenging for a society to maintain social distancing. With many of our parents and grandparents identified as at high-risk population, we can't help but worry about them. When my 70-year-old father, who is still a functioning lawyer in highly crowded Egyptian courts, was convinced 2 weeks ago by his friend that COVID is not a virus, but a toxic gas that already evaporated from the earth and is no longer dangerous, I can't help but worry. When the streets of Egypt are still full of people who are using the masks to cover their eyes in transportation to protect them from the sun instead of the virus, I can't help but worry. When I hear that all hospitals are saturated in my parents' city with COVID patients and I fight only on daily basis with my father to convince him to stay at home, I can't help but worry. When my family members overseas communicate COVID symptoms that they are experiencing to me, I can't help but worry. All that I hope for is that my at high risk family members overseas manage in a way or another to make it to the 30% left over of a society likely reaching the herd immunity very soon before a vaccine is available. On a more personal level, amid the pandemic, my destination wedding was put off to God only knows when. A 12-month plan, including reservations and tickets worth thousands of dollars for us and our family members, were all suddenly in jeopardy. Additionally, risking the health of our family members was of course unacceptable. An alternative plan was just my fiancée and I, along with a priest and 2 witnesses. Even that sounded impossible with nowhere to get a marriage license from. Everything was uncertain. We don't even know when this all will be over. Till one night that happened to be my last night of work before a 2-week vacation, when my fiancée's parents in Florida found out that marriage licenses over there will be issued to out-of-state residents the following week. We flew overnight to the Sunshine State, and in 2 weeks, a couple of days play by ear, wedding preparation, happily exceeded the expectations of a 12-month destination wedding plan. With less than 10 people inside the church following social distancing, and few other members outside cheering, we exchanged our vows while streaming to our families and friends everywhere in the world. Our wedding was a pleasant surprise to everyone. It gave us hope that no matter how dark the night is, the sun will rise brighter in the morning. At the end, I would like to thank all the residents, my colleagues and friends who I'm proud how responsible they are in response to the pandemic, each with their own perspectives and personal statements. And don't forget, the sun will rise again very soon. Thank you.
Thank you, John. We're going to wind up going a little bit over, but I don't think anyone cares. This is so great. I'm going to let John and Pat have their time, and just take your time and go for it. Our next speaker is John Janier, who's going to represent the primary care docs. John.
Thanks, Brad. I really appreciate this. So when Brad asked me to speak today, I really wasn't sure what to say. And as Laurie did, I did much like Laurie did, going back looking at my calendar. In the first week of March, I felt like I really knew what I was doing as an internist. Busy, seeing patients, everything was going great. March 16th, everything changed. And suddenly, simple decisions that I never had to make before. Do I really need to see this patient in the office? Who's sick and who's not sick? This patient may have COVID. Should I see him in the parking lot so I can save my staff from being exposed to them? Am I putting my PPE on? Right, wrong. Am I going to have enough PPE? I'm in private practice. There were no easy ways to get PPE. It was all spinning in my head, and it was very difficult. We talk a lot about telemedicine, and I love reading all these articles, how this is the new medicine. I'm going to be honest with you, it's not the new medicine for me or my patients. It's not what I want to do. It's not why I got into medicine. I like the personal connection. I had a patient the other day, he came in and he said, your office offered me a telemedicine visit. He goes, I get to see you once a year. I really want to see you. And that meant a lot. And yet you want to make sure that you're doing the right thing for patients. And that's the real struggle. I think of Bob and Pat, and every time they do a surgery, they talk about risk benefit. They talk about the risk of having a surgery. Never in my life did I think as an internist I'd have to talk about the risk of coming in my office. And yet we've set up the protocols. We're cleaning the office. We wear our shields and our masks. Patients call me and say, John, is it safe to come in? And I say, have you been to Wegmans this week or Home Depot? And they said, yeah. I said, well, I think I'm a little safer than that. And so it is the new normal. And I finally came to that conclusion 2 weeks ago. Attending grand rounds, listening to Emil speak, understanding that this will go on for a while, I finally had to come to peace with the fact that I have to be a doctor. I have to do what's right for my patients. And I have to do what's right and what they're most comfortable with. And I'm fine with that. If they want to do a telemedicine visit, I'll do it. Honestly, the adoption of telemedicine in my practice is about 10%. Everybody else wants to come in. For years, we've told people, you know what? Healthcare is so important. We need you to come in for your physicals. We've built an entire generation who on high deductible plans, the only time they come to the doctor is for their free physical. And suddenly I'm supposed to say if physical is not that important, it's not essential. We can argue the literature. You can say academically, boy, physicals, most healthy people come in, you don't find a lot on physicals. But there's a bond, there's an ability to talk to your doctor that patients really enjoy, the real care part of medicine that we provide. And so I'm going to keep doing physicals. If they want the physicals, I'm going to do them. I'm going to do them the appropriate way. I'm going to do them safely. But I'm going to do them because that's what they want. On a professional level, in terms of private practice, this is the scariest thing I've ever seen for private practice. So for many of my colleagues who are employed, you've had incredible stress at the hospital and dealing with all the different issues in terms of protocols. We had to run around and try to find money to keep ourselves going for 3 months. We got the PPP loan, thank God, because my partner and my office manager came in at 9 o'clock on a Saturday night and spent 2 hours filling out the form. And so luckily we didn't have to lay off our staff and we could continue through this. But I do really very much worry about the possibility of a second surge and what happens then. But we're going to try to keep this going. I've looked at, as a leader at the PO, I've looked at how many physicians we have who are older. And I'm afraid we're going to see a rash of retirements in the future and how to fill those shoes. So that's what worries me the most. Personally, I think 2 things have come up. One was very early on, I wanted to volunteer for the surge. And so I started to do the paperwork. And then I realized I'm over 50. I have hypertension. And it was this big struggle because I never thought of myself as being someone who'd be at risk. And suddenly I had to kind of face the fact that maybe I was a little at risk. And I kept filling out the paper and I screwed up the paperwork. And I realized I was screwing up the paperwork because I just wasn't sure I could do it. And eventually I did, and I became comfortable with it because, as Laurie pointed out, we became comfortable with what this COVID thing is. We're starting to figure it out. But there was a time when we didn't, and it really was tough to decide how to do that. And I was happy that I didn't have to do the surge, and hopefully we're never going to have a surge because you don't want me back in the hospital anymore because I'm not that good at it. But the reality is that was one of my decisions. On the flip side, I do think it has made me slow down my life. There's been some good things about this, which is very strange for it to be a pandemic. I like having my 2 sons home for dinner, 21 and 24. When's the last time I had dinner with my kids? Probably when they were in 5th grade before sports started. And so we're hanging out and having dinner. Sometimes they even cook for us. We actually have Takeout Tuesday, which is awesome. We each pick a place to go for a restaurant, and it's really fun to do that. And so there's that bonding time that I never thought I'd get back with my kids. It also makes you stop and think about what's important. And I definitely want to slow down a little bit. I don't miss 14, 15-hour days. They're starting to come back, but I want to make sure that I take care of the family and take care of myself again, because that's what this has made me think about. The thing I miss the most are colleagues. This is a great grand rounds, but I love sitting in a room with you guys. I love having conversations. That is so important to me. And that's one of the reasons I've stayed in leadership so long, because of the people at Rochester Regional. And today is just a great example of hearing everyone speak. It's very moving to know who we work with and how important patient care is, but also to understand their own experience. And so I really appreciate this opportunity, Brad. I think this has been great. I look forward to hearing from Patrick, and I want to thank everyone. And we always talk about we're in this together. Well, I want to say we'll be back, because we're going to get back to what we were doing before. Thank you.
Great. Thank you, John. And then last but not least, some of you are probably wondering why I invited Pat Riggs, but I'm going to let him tell his story. Pat, you got to unmute yourself.
Thanks. They're cutting the grass out here if we get background noise. I'll jump straight to the punchline. I know we're short on time. I think
You got plenty of time. Don't worry about it.
Probably one of the few people that experienced it firsthand. I was tested positive for COVID, and a number of the people in our vascular division were tested positive for COVID. So we had a situation in the very early days before we were all masking, which was a mistake. That was one of the things we learned. We were having daily huddles in the office manager's office to decide what we were going to do about rescheduling patients, who would need to come to the office, who could be seen remotely. And 4 of us ended up getting COVID. So my office manager had a cough first. He called me. I made some phone calls. Dr. Leschko, shout out to Roberto Vargas. Some of the people were extraordinarily helpful in helping me navigate the system to get them tested. He tested, we expedited his test, he tested positive. Within 24 hours, one of my APPs that saw inpatients and outpatients said she wasn't feeling well, symptoms a little different, was en route to get tested in Batavia. I rerouted her back here. Dr. Vargas offered to expedite hers, and we had a positive test in her. About 24 hours later, I was seeing now we were all wearing masks. About 24 hours later, I was seeing a patient transferred up from another hospital that needed a fairly complex operation. And in the room with the patient, I got this dry tickle in my throat, and I started coughing, and I had to walk out of the room. I was coughing so bad, and I thought, oh boy. So I left work that day. I got somebody else to attend to the patient, went home, and my initial plan was we have a summer home on the lake. I called home, hey, why don't you just move to the lake house? I have 2 19-year-old children who thought, this is it for Dad. We don't want him away from us. And they absolutely refused that plan. So I stayed at home on a floor by myself. Within 24 hours, my son had exactly the same symptoms. And then 2 girls in the house sometime after that. For me, the experience was like having the flu. So it started out with a cough, kind of a dry cough. I had a headache, and the biggest symptom was fatigue. Fatigue was significant. Walking up a flight of stairs, you felt like you needed a nap. Importantly, one of the important lessons is I never developed a fever. All 4 members in the household eventually became symptomatic. None of us have a fever. And I think that's important because I believe we as a system are making a mistake to make the symptom of fever a prerequisite to be, early on, it was a prerequisite testing. And you'll miss 50% of the people. So when I went home and I self-quarantined, within 24 hours later, my son started coughing, exactly the same cough, headache. Gee, Dad, I got the fatigue. So we kind of quarantined together after that point, but his symptoms were exactly the same. I said, you got to go down and get a swab. And at that point, my wife was starting to feel sick. She had more of a headache, severe fatigue. I sent them both for a swab, and they got temperature checked, and they were both denied a swab. So, we live in a house with a person who is a known positive, who actually had the highest viral load of anybody tested throughout the RGH system. And we both have exactly the same symptoms that he has, and they're denied testing. So those kind of fights we had, and I think Bob helped me eventually get we were pushing to get the whole vascular team tested because our patient population is extremely fragile. You know, they all have severe comorbidities. The average age of the person I operate on is mid to late 70s. So we really, really have to be anal about potentially exposing those people. And it was a fight. I think, you know, the fear of running out of testing swabs was a big concern, but we were extremely nervous about testing people. So I quarantined at home, and like anybody else's experience, it was moderately miserable, you know, just to be at home and know there was work to be done and feeling rotten and all those kind of things. But it was very similar to the flu. I came back, so I had to make a decision about when you come back. And for anybody, if there's a second wave, that will be a decision, if you get it somewhere, a decision you'll have to make. The systems policy is a week out of work and at least 72 hours without a cough or fever. I was getting called from the system, and I was also getting called from Monroe County Department of Health. Monroe County Department of Health, the recommendation is 2 weeks. And so I stayed out a total of 16 days. When I came back to work, we had an emergency transfer from another hospital with stroke and evolution, you know, critical carotid stenosis with ongoing neurologic symptoms that needed surgery. He was already on droplet precautions because he had a nurse at the other hospital that was positive. So we had full PPE equipment with his care. I operated on him. He subsequently became positive. And of course, there was an inquiry in why the hospital would allow me to operate on this person after I'd been positive. So that is another thing to navigate. So I got a second test at some point, still testing positive. And then the question became for me, should I get another test at some point down the road? And what are the legal implications? Because now I'm back to work and I'm operating on people. I'm afebrile, as I've always been. I'm asymptomatic. But what is the hospital, the system's liability in me operating on people, which are only emergency operations at that point, and you know, their fear of being exposed by me. So that's another navigation. My son went through this. My son, 19-year-old son, is still in a position. Now we're 2 months out. My son is still in the position that last weekend there was a sleepover and a pool party, and he didn't go. I thought it was odd because it was a bunch of his friends from high school, and they're all, and he said, you know, I'm still in a position where either some of my friends are uncomfortable for me to be around, or, you know, their parents are uncomfortable for me to be around. And that's another thing to navigate. Now, subsequently, he went back. He's been tested again. As the testing has been liberalized a little bit, he is swab negative. And I think that has given, but that absolutely is something to navigate because, you know, your responsibilities at work, your, you know, need in emergency situations has to be balanced with people's fears, colleagues' fears, the nurses, you know, they had fears. That was part of our reasoning for checking the whole vascular team is the OR nurses, they got to be afraid of the patients. Now they have to be afraid of working with other staff members. So I think all those things are justifiable fears that we will have to navigate. And I think if there is a second wave, whether it's from hospital exposures, because we operate on COVID patients, there are times, there's been a handful of folks that we knew were positive, but they needed emergency operations. We got to take care of them. We will have hospital exposures. We will have community exposures. And presumably, some percentage of us will be positive. And then what do you do? And that there's a healthcare navigation and a psychological navigation that comes with that. I think the big takeaways that, I would say is that you'll have to make your peace with it. You'll have to make your peace with the hospital policies. You'll have to make your peace with the colleagues that you're working with and your family. Dr. Lerner, I get it. The issue about navigating kids at home. Do we isolate? Do we not isolate? The biggest, so I was on prednisone when this happened, and I think a biologic immunosuppressant too. And I've had pulmonary problems. So I think one of the big issues navigating it in my family was, they had significant concerns about me deteriorating if I was remote from them and nobody being around to witness or, rescue that. It turned out not to be a realistic fear, but that was another concern. I think we've learned that fever may not be an impediment to testing people. I think we have learned that probably direct human spread is significantly more important than contact spread. I think the science is bearing that out, and I think that's how we all got it in our situation. I'm happy to look and see if there's any questions, but
I don't see a single one. I think people are just mesmerized by that description. I can't imagine what it would have been like in the second week of the illness when you're waking up every day wondering whether, this is going to be the day that you get short of breath. And sometimes it's not good to be a doctor and know what the possibilities are.
Yeah. Well, we were all quite fortunate, but, we saw the full range of symptoms. I was probably a little worse, and my son had very similar symptomatology. My son is a 19-year-old athlete, and he had very, very similar symptoms and had very severe fatigue. Here's a kid who's, swimming 10 miles a day on the swim team and would walk up a flight of stairs and absolutely exhausted. And so his symptoms, the females in the household really seem to have a lighter symptomatology. And I think there is a male-female difference in what we're seeing. My wife, went to bed and slept for about 2 days and then got up and was kind of okay. And my daughter had, 1 or 2 days of feeling bad and a slight headache, and that was about it.
I just think we have to be careful not to trivialize the disease process. We don't want to give people the impression that it's just like the flu.
Yeah.
It's a lot more deadly. It's a lot more contagious. And, and then we just have to be careful with that. We were all challenged by the testing limited availability. It wasn't that there was a policy that was more liberal or more restricted. We would have loved to test a lot more people than we could. Due to the failure at the federal level, nobody could test anywhere near the amount of patients that needed really to be tested.
Yeah, I think in terms of the symptoms, certainly we were on the light end of the spectrum. I think for whatever reason, and, I wondered in retrospect, maybe the prednisone was actually helpful to me in the immune response. For whatever the reason, I never got the pneumonia or horrible shortness of breath type symptoms.
Got lucky in some ways, right? Yeah. So one of the comments was maybe the women are just stronger. I guess. Right.
I think that's probably absolutely.
With that, I'm going to call this a Grand Rounds. I did tape this, so we'll have a YouTube video of this that you can offer to people who couldn't participate.